Hello everybody. Today I'm going to present a female Fabry disease patient with cardiac involvement. X-linked recessive inheritance describes conditions in which the phenotypic trait is manifested in males and transmitted through asymptomatic or carrier females. Fabry disease is the most prevalent lysosomal storage disorder which has X-linked recessive inheritance. Mutations in the GLA gene result in a deficiency or lack of the enzyme alpha-galactosidase A, which leads to lysosomal accumulation of glycosphingolipids, major one being GB3, in a wide variety of cells. Males with the classic form of Fabry disease are null mutants, which means they have almost no enzyme activity, whereas females and atypical variants have higher enzyme activity. The threshold level of alpha-galactosidase A activity, below which clinical manifestations are seen, is around 30 to 35%. GB3 accumulates in multiple tissues leading to renal, cardiac, neurological, ophthalmologic, dermatological, and GI manifestations. The most common renal manifestations are proteinuria, isostenuria, and kidney failure. Cardiac involvement can be in the form of myocardial fibrosis, heart failure, coronary artery disease, isolated left ventricular hypertrophy, arrhythmias, valve abnormalities, and conduction abnormalities. Neurological manifestations are neuropathic or limb pains, TIAs, and strokes. Ophthalmological manifestation is cornea verticulata, which is a golden brown, whirling corneal opacity. Our case is a 55 to 60 years old female who has a long history of recurrent unexplained abdominal pain, for which she was evaluated with colonoscopy, endoscopy, and CT imaging without a diagnostic yield. She also had recurrent headaches. She presented to ED with palpitations, and EKG revealed supraventricular tachycardia, which was terminated medically. Transthoracic echocardiogram at the time was normal. Later, she presented with chest pain, elevated cardiac enzymes, and ST segment changes. She underwent coronary angiography that showed normal coronary anatomy. Because of the non-specificity of the symptoms, Fabry disease was not included in her differential diagnosis until her optometrist recognized verticulata during an annual eye exam. She was referred to genetics department for testing, which revealed a GLA variant, so a missense mutation in PC387Y. Later, she had cardiac MRI that demonstrated non-ischemic fibrosis consistent with cardiac involvement of Fabry disease. She was diagnosed with cardiac variant FD, and enzyme replacement therapy with galactosidase beta was recommended. This is her pedigree, and arrow points the proband, so our patient. Her father died secondary to anemia at age 56. He also had CKD, both of which are well-known clinical manifestations of FD. We think he was an undiagnosed Fabry disease patient. Consistent with X-linked recessive inheritance, his both daughters are heterozygous and his son is normal. The proband, so our patient has 3 offsprings, and both of her daughters are found to be heterozygous carriers. In 1960s, the inheritance pattern of FD was defined as X-linked recessive. Heterozygous females have historically been described as asymptomatic carriers until early 2000s, but recent data have shown that 10 to 15% of affected individuals are females. Their clinical presentation can range from asymptomatic to clinical severity similar to that of males. Responsible genetic mechanism underlying the phenotypic variability in female is random X chromosome inactivation, also called lyonization. Lyonization, which is named after English geneticist Mary Lyon, is a process by which one of the copies of the X chromosome is inactivated in females. Depending on the pattern of X inactivation, there are three possible outcomes. A cell can have only normal, both, or only mutant X alleles. And this skewed inactivation of normal X allele leads to clinical disease. The severity of disease and the type of organ involvement depend on which tissues have the mutated gene activated in a significant majority of its cells. You can keep this concept in your mind with the help of this cute cat. This is a calico cat, which means three-color cat. The patchy distribution of the color on this cat's fur results from the random inactivation of one X chromosome in female cats. Diagnosing Fabry disease is important because therapy in the form of enzyme replacement exists and it is highly effective. Key step in diagnosing the disease is to have a high degree of suspicion. This is especially important for female patients. A recent study showed that the mean delay to correct diagnosis is 16 years in females versus 13 years in males. To raise awareness for female Fabry disease patients, National Fabry Disease Foundation organizes a meeting named as Annual Fabulous Fabry Female Meeting. To summarize, genetic metabolic disorders like Fabry disease may present with a wide spectrum of clinical manifestations similar to other common adult conditions. Female Fabry disease patients need special attention because they are underdiagnosed due to the misconception of disease carrier state in X-linked recessive disorders. Close follow-up and enzyme replacement therapy improves outcome in these patients. So it is important to include genetic metabolic disorders in our differential diagnosis.